Hey y'all, welcome back to my channel. I'm Muriel. This is Nurse Muriel. I know it's been a while. Y'all know I originally, when I was doing those videos, dropping them like 2 or 3 a week, I had dropped down to 2 days a week of work. And I actually had time to do all of that. But recently I've been working like for about 4 days, averaging a week because y'all, it's getting hot. And I was like, oh goodness, let me hurry up and get to work so I can, pay down some bills because I want to be able to drop back down to 2 days a week this summer. And so now I am to that point, y'all. I'm going back down. After this month, I'll be going back down to 2 days a week. So I'll be able to drop these videos more frequent like I was doing. Let me say welcome to my new subscribers. I am at 720. Thank y'all for seeing something in my videos and deciding to hit that subscribe button. Hey to my oldies but goodies, how y'all doing? I know I've been promising some videos, y'all, and if excuse me if I seem a little blah, but I'm feeling a little under the weather. To be honest with y'all, I think I have COVID again, either COVID or the flu. I'm about to go upstairs and take a COVID test, but yeah, so I'm not feeling all that well, but I'm home, so I said, okay, let me go ahead and do a video. I'm going to talk about ways to cover your as a nurse in long-term care. Y'all know I was in a prior video, I talked about how I had a patient who was having who had a high blood pressure, and how the NP or the PA or the MD, I don't know what they were at that time, didn't want to address it when I brought it to their attention. And because of, I think honestly it was because of the look I gave them, they decided to go ahead and address it, and they did put the patient on a blood pressure, a hypertensive medication. And so these videos will be a few ways to cover your behind as a nurse in long-term care. So like I just discussed, one was with a patient who's hypertensive. Most long-term care facilities will, the doctor, the resident doctor, or whoever will have a protocol set for a protocol or parameters for every patient, so where they want to be notified if the blood pressure is over a certain amount. So one facility I work, anything systolic over 160, pulse greater than 100, respirations greater than 22, and sats lower than 90%, they want to be notified. But that's just like an overall rule. That's not per patient. That's for every patient in the facility. And so when you're going and putting in vital signs for your patient, some facilities, the techs do it. A lot of CNAs, I call them techs from my time working in the hospital. I call CNAs techs now. So you'll hear me interchange that. A lot of facilities allow the techs to put vital signs in, but there are some facilities who do not allow techs to put vital signs in, because there have been times where techs have been putting in blood pressures of 180 over something, heart rates of like 110, and the nurse know nothing about it. And these are vital signs that need to be reported to the MD as soon as they're put in. So a lot of places discourage the techs from putting the vital signs in. They allow the techs to collect the vital signs, but they want them to then be given to the nurse to at least look over before they are input into the system. And so anytime a vital signs, which is greater than that parameter, the nurse is supposed to notify the MD. So I'm letting y'all know to cover your behind. If you have a vital sign that's out of parameters, my suggestion is, because a lot of times these vital signs are taken prior to blood pressure medication being administered, or sometimes your oxygen saturation is taken with a nasal cannula outside of the patient's nares. And say you're getting a blood pressure of like 180 greater than something, go ahead and administer whatever scheduled BP meds are due, and then recheck the vital sign, because it's possible that you'll get, a more therapeutic range if you wait until the medication is administered. But if by chance it is elevated or low, say with the O2 set, notify the MD, even if you have to notify them via their notification book, or if you need to notify them via fax, or if you need to notify them via phone call. Make sure it's somewhere documented that you notify the MD of this vital sign that's out of range, and that you document in your documentation that the MD has been notified. That's how you cover yourself, as well as with blood sugar. So we all know if you work facilities often, even if you're an agency nurse, you can kind of get to know some of your residents. So there sometimes will be those residents who, in the morning, their blood sugar is going to be like 50s or 40s if you gave them their nighttime insulin. So say you have a patient who gets a scheduled 55 units of Levemir or Lantus at HS in 5 p.m., 8 p.m. or whatever, and you give them a nighttime snack, but that when you check their blood sugar, 9 times out of 10, they're still going to be like 60, 50 or whatever, because bodies react to breaking down sugars differently. And everybody's body is not going to react to an insulin administration the same. So you may have this one patient, you give them 1 unit of Novolog. Say you check their blood sugar at 9 p.m. and their blood sugar was 250, and you administer 2 to 4 units of insulin. That patient blood sugar may be 60 in the morning, because that's how their body reacts to Novolog. Another patient blood sugar may be 300 in the morning, because those 2 or 3 units doesn't do a thing for them. Like when you start to regularly work with a person, you kind of get to see these patterns. And so my thing is, with a person who is hypoglycemic, say you administer their 50 units of Levemir at night, and this person gets their nighttime snack, but you just know from working with this person 9 out of 10 times their blood sugar is going to be 50 in the morning. And say you're the nurse, you go and check their blood sugar, and as expected, say it's like 62. And to cover yourself, if the patient is alert and oriented and you're able to give them something to eat or drink, because that's what the note should tell you to do anyway, to give so much apple juice or whatever it says to give. You go ahead and give this patient this, but then you check their blood sugar, say 30 minutes, 15 to 20 minutes, 30 minutes post them drinking that, and now their blood sugar is 78. Okay, they're within a therapeutic range to where, say you put that 78 in the computer, but you don't put the 60, what did I say, 62? Okay, technically, you should have put that 62, but say you're the nurse who you want to put that 78. Okay, you put that 78 in the computer. Now what you should do is you should still notify the doctor that, hey, patient's blood sugar initially was 62. Patient was given apple juice or whatever, blood sugar increased to 78. And then also let the doctor know this patient receives 55 units of Lantus or Levemir at night. That doctor may decrease those 55 units to 50 units or 45 units, especially if you put in there that this is a pattern that patient's blood sugar is below 70s in the AM. That doctor will more than likely decrease that insulin that they received the night before. But say you're that nurse that you're going to go with that 78 and you're just going to put that in the computer, then all that's going to keep happening is the cycle will keep happening. No one else probably notified the doctor, because I'm telling you, if someone else notified that doctor, he or she would have decreased that nighttime insulin. So just go ahead and notify the doctor, hey, patient's blood sugar was, and this is a pattern, patient's blood sugar has been running below 70 on the AM checks. Patient receives such and such units of insulin at HS. The doctor will decrease that insulin. And so you'll have taken care of the problem. So it's not going to keep persisting night after night after night after night. And I'm going to be honest, a lot of nurses like to just take it in their own hands. And they just like to say, oh, well, I'm not going to give these whole 55 units because I know this person's blood sugar will be low in the morning. We all have been that nurse. Let's be honest. We all have been that nurse. Don't be that nurse, y'all. Just go ahead and let the doctor know so the doctor can decrease that insulin, because you're the nurse there 3 or 4 times a week. What about those other 3 days when it's maybe a different nurse or agency nurse? Or what if you're only going to be there, say you don't know it's a pat, say you only work there 2 days a week, but it happens with you every day that you work. So 9 times out of 10, it's probably happened every night those other 4 or 5 nights that the other nurses work, but they're not going to take care of it. And you may feel being an agency nurse is not your responsibility, y'all. Don't be like that, y'all. Just go ahead and notify the doctor. Even if you don't call them, you don't have to call them. You can just write it in their book. Resident regularly runs below 70 in the AM. Regular patient is given apple juice or whatever. Blood sugar does increase. However, resident does receive 55 units of insulin at HS. And make sure you document this notification in your notes as well. Another way you can cover yourself, say you're getting a new admission. Always do a patient's body audit, y'all, when they come in for a new admission. Document whatever areas you see upon admission. Make sure they're documented, because there have been times where patients have come in to a facility and a pressure sore or a pressure wound or whatever has not been documented. After so many hours, the facility has to eat that as a facility acquired whatever, bed sore, bruise, whatever. And the facility has to eat that, y'all. So as the nurse, just cover yourself. Just go ahead and do the body audit head to toe on a patient when a patient arrives. Another way to cover yourself in a facility is to do your narcotic checks, y'all. I've already done a video on this. Please do your narcotic checks, y'all. Y'all would be surprised. And I'm just going to be honest. Y'all would be surprised how many nurses out here still in narcotics. There are quite a few. If you're counting narcotics, when you do your narcotic count and you see that you're counting fentanyl patches in the narcotic thing, find out what patient this is and go make sure that narcotic patch is in place on that patient before the nurse you're relieving is gone. This has happened so many times. I work at a facility that whenever I came in to count, and now I'm not going to lie, I would not go and check the patient to see if the narcotic patch was on. But when I'm documenting, it pops up on the MAR that we're verifying that the narcotic patch is in place. And it's been several times that it wasn't in place. And it's known to not have been being in place. And they just will let it be like, oh, well, it's never there. It's never there. Never there. But are you giving any thought to this patient who needs this pain patch? Like, they are suffering, they're on the fentanyl patch. They're on it for a reason. So what you should do is put another patch in place. But to avoid all that, y'all, when you're placing a fentanyl patch, just put some tape or an offsite, put something over the patch so it'll stay in place. So it's one thing to just say, oh, no, it's not in place. But when you think about it, this is a pain medication that this patient isn't getting. This is pain relief that this patient isn't getting because their patch isn't on them. And what I should have done was actually placed another patch on them. But if you keep doing that, if you keep replacing a patch, if you keep placing a patch on a patient because there wasn't a patch in place, pharmacy is going to start to wonder, why are you running through so many patches? If we gave you 5 patches and that should last you 15 days because you replace them every 3 days, why are you ordering new patches every week? So pharmacy will start to wonder, and that'll be a whole nother can of worms. Yeah, I can't really think of anything else right now, but if you enjoyed this video, hit the like button, subscribe to my channel. My next video, I'm going to come back. So someone asked me something else in this, in one of my, I got to go back and look at some of the questions. I'm trying to do all the video requests now. Anyway, y'all, thank y'all for viewing. I'm going to try to drop another video in about 2 days, another video in a couple days. I'll talk to you guys later.